Intrarecti distance has been the golden standard of measurement and outcomes when treating diastasis rectus abdominis. But should it be? Listen in as physiotherapist Diane Lee shares why we might want to use something else instead. Hello, friends. This is Lynn Schulte, and you are listening to the Birth Healing Summit podcast. We are here for meaningful conversations that will transform the way you work with pregnant and postpartum clients. Whether it is a new perspective, tool, or technique, you'll be able to implement it into your practice today. I invite you to sit back, listen with an open mind, and grab the golden nugget today's guest has to offer. Now let's get started. Boy, do I have a treat for you all today. We have with us Diane Lee, and she is a physio up in Canada. She is a mentor. She has done it all, everybody, and we are so blessed to have her here with us. Diane, welcome to the Birth Healing Summit podcast. I'm so grateful that you're here.
Yeah, thanks, Lynn. I'm happy to be back.
All right. You're still here, right?
I'm still here. I'm still at it. No stopping.
That's
no end in sight. Yeah.
Awesome. We are so great. You know, I've always said that I don't think I'll ever retire because I love teaching too much. And, you know, if you're teaching, I still want to have my hands on people. So I'm still learning, right?
Absolutely correct. Absolutely. Yeah. I mean, it's our lab, right? It's where we learn the most. And it's what proves us wrong and keeps us humble and keeps us knowing what everybody's going through. And how can you profess to teach when you have no idea what the community is like? I don't understand.
Right. And you know, and we're gonna keep doing it until, like you said, our mind and our bodies don't allow us to do it anymore. Our faces may be getting older, but working keeps us sharp, right?
Yeah, and the decision to stop dyeing my hair has been an interesting journey because people get scared when they see that you're a silver fox. They think that, oh, this means that, you know, you're going to stop. And why does hair color mean that you can't think? Or it's been an interesting journey. Yeah. No need to stop. Yeah, you're right.
No. Because you know what? That passion lives on and that passion drives us. And you truly have a passion for sharing your knowledge with us. And we are all forever grateful for all that you share with us. And so you have, you just recently updated in a new edition of your Diastasis Recti book, correct?
I did. It's now an ebook because printing paper is hard on the planet, and also shipping paper is hard on the planet, and it's expensive. And the first edition didn't reach a lot of people that were not within North America. So we decided to go to an ebook, and people say, so what's different in the ebook? And what we didn't have in 2016 was I'm not saying we have it now, but we have a clearer understanding now of the moderate to severe DRAs and whether or not we should be training them any differently or not. And we're just getting a clearer understanding, both from the evidence and clinical practice, is how to help these women start to navigate and manage the biopsychosocial factors, because all three are involved with this condition. And so there's new cases in the book. There's sections in the book that talk about, you know, what's relevant for training those with mild DRA, which is what's relevant for those with training larger ones, because people get their knickers in a knot when they think, oh, it's bulging, it's doming, and that's not allowable. And it's not true. And so we're going to be addressing some of that today about, you know, this crazy gap in the interrecti distance. And yeah, so that's all updated in the new guide. Awesome. And it's more than a book, right? Because it has over 200 videos online of both assessment and training videos that are sort of part of my education platform as well. And so it has it's a combination, like a hybrid product, put it that way. So
awesome.
Hopefully useful.
Yeah. Awesome. All right. Well, so today we're actually going to be diving into, is the IRD, so the interrecti distance, an appropriate tool for us to be using with assessment and treatment? So what do you have to say about that, Diane?
Can I share my screen?
Sure, please do.
Like that.
I think so.
Thanks. All right, Lynn, here we go. I want to talk for the first part of this podcast, for the presentation. I want to address this interrecti distance because There really has been a conflict or a disagreement between the research evidence and our clinical experience. And in the sense that there's been a lot of emphasis put on the interrecti distance in research. It is the measuring tool they use to classify DRA, whether it's mild, moderate, severe, although we can't agree on that number. And there also is confusion with respect to what does it mean when it stops changing. So when it narrows in the first, few weeks, months, maybe up to a year, a little bit more after pregnancy. And then for many, many women, it doesn't change. It stops after that. And then the goal becomes, how do I make this gap go away? And the focus is on the gap, even in spite of tons of evidence and systematic reviews that have not been able to show that there's a consistent symptom that is actually related to that gap. Right. Mm-hmm. So many still thinks this is a cosmetic problem. And for some, it really isn't. So that's what I want to talk about today.
Okay, great.
And so I'm going to take you back to the research that Paul Hodges and I did from 2007, leading up to the publication in 2016 of this whole interrecti distance thing and how it behaves. So our fingers are the measuring tool that we use to measure interrecti width or distance in clinical practice. And the gold standard for research is ultrasound imaging. And more we're starting to see, as prices come down with ultrasound machines, that many of us are starting to use ultrasound imaging as the tool for measuring interrecti distance. And what I don't understand in the research is that they classify these people measuring them in a curl-up task, not at rest. Well, a curl-up task is really about strategy. It's about motor control and what your abdominals do. So there's no correlation between women who have, let's say, a 4.5 centimeter separation at rest when they're not doing anything, no activation other than postural tone, and those who have a 4 centimeter correlation when they curl up. Those who have a 4 centimeter separation when they curl up may have an 8 centimeter separation when they lay down, or they may have a 4 centimeter separation. So it's very strange to me that this is what they use in research, is the curl up as a classification for how wide are you anyway, right?
So why wouldn't you just use at rest, Diane?
Yeah. Why not at rest? Because isn't it a structural, it's obviously it's a functional and cosmetic impairment, but if you want to know how wide it is, I think the important measure is not only at rest, but it's when the lateral abdominals pull it wide. Like, how wide can this thing really go, right?
Yeah.
We'll give you an idea of how long is that rope? How long is the fascia?
Yeah.
My question has become, and there's several clinicians and people over the world who have stopped caring about the interrecti distance. And I've asked myself, is it a valid measurement for determining plan of care? Like, number one, how do we train these women? And more particularly, its outcome. And what do we mean by outcome? What is a successful recovery from a diastasis? Is it how you look? Is it how you can lift? Is it how you can rotate? Like, what is I'm better to one woman is I'm terrible to somebody else because of all the different parameters in this condition, right?
Yeah, I was just going to say it's totally up to our patients, right? As to what they consider better.
Totally.
What they're wanting.
Totally.
Yeah.
So there's been several studies, and a few of them are listed here, and there could probably be a lot more who have shown. And if you look at the ultrasound videos over here, I'll orient you. So at the bottom one, this is one rectus abdominis on the left here. This is another one, and this is a linea alba connecting the two, and it's fairly straight. You can see it's on an oblique line, either because the probe wasn't straight or because the person has rotated. One or the other. You can't say why, it's oblique like that. But then when this individual does a curl up, you can see that the left and right rectus abdominis come together. They come closer together. And the linea alba in the middle has this doming shape, and it certainly doesn't look tense and straight like the one below. And this is the same person. This is her contracting her abdominal wall and pulling it wide. And this is her just doing a curl up without that. So this short head and neck curl up has been called an abdominal crunch, and many studies, including ours, has shown that it, brings the recti together, it narrows the distance. Whereas when you do a recruitment of your transversus abdominis, whether it's through a pelvic floor cue or whether it's through an abdominal cue, because those two should co-activate, but they don't always, that often the result is that it widens this interrecti distance. And the clinical recommendations, not from us, but from all the other authors or researchers on the top of the slide, they say that exercises that recruit TA should not be given to women with DRA, and that they should do abdominal crunches instead, with the sole goal of narrowing this interrecti distance. And when this came out some, 7-8 years ago now, many of us just shook our heads because we went, hang on, the women we'd seen before had come from gyms and had come from their own programs of just trying to get stronger, doing tons of sit-ups, and it hadn't been successful for them. And when we started applying the evidence from the early 2000s on how the abdominal wall should work, collectively and in synergy, the whole thing working together, they finally started to improve. So the evidence was absolutely, and suggestions was absolutely polar opposite to what we thought should happen.
Yeah. And
in one of these latest studies, I've met Sandra in Norway, and I'm sorry, Sandra, if I get your name wrong. I'm not sure if it's Gloop or Gloope. It's Norwegian, so I'm not quite sure how to pronounce it.
Okay.
So from her 2020 study, she basically said, because this was a study looking at the effects of a pelvic floor contraction and TA on the interrecti distance, but her interpretation, listen to this, our results indicate that a curl up may counteract the negative effect of a pelvic floor muscle contraction on the IRD. Here's a judgment. What's a negative effect? Yeah. It's an assumption that making this go wide is a bad thing, right? It's a bad thing. This is what I want to challenge, that the whole myth that the interrecti distance getting wider is a bad thing. It's a bad thing, right? Yeah. Yeah, because this conclusion assumes that it is, and the IRD is a valid measure for planning, training, and measurement outcomes. But is it? So this is what it looks like. So this gal does a curl up. You can see she has a nice separation, and you can see the interrecti distance here. You can put one finger between that. And then when you get her to connect her low, middle, and upper fibers of TA, you can see it's gone wider. You can see that's gone wider. And when she shuts the deep system off, boom, it comes together. Okay. Wow. So what does this mean is what we're trying to interpret. So the Nordic group would tell you that she shouldn't be pulling it wide. She's going to make it worse. And I personally think this has led to a lot of catastrophization from both clinicians and trainers and women in general. Oh, I can't do this. I can't make this go wider because I'm going to pull it apart, which is absolutely not true. But yeah, what does it mean, right?
So I just want to interrupt there real quick and let people know, if you're listening to this in the podcast and audio only, please go to our YouTube channel and you'll get to see the video of what Diane just shared there. So on our YouTube channel, Institute for Birth Healing, you'll be able to actually see the video of this. And that was pretty interesting to see this gal curl up, contract, things come together. But when she activated TA, the intra-recti distance actually widened. So, and then when she let it go, it just kind of collapsed all in the middle there. So
yeah, because there's no lateral anchor. When you think about, and transversus is the only muscle that does this. The external and internal oblique don't do it. So when TA contracts, it anchors the lateral part of the rectus abdominis, pulls it wide. And so then when you curl, you have some kind of connectivity maybe between the left and right sides. It depends on several things that we're going to get into. But then when she lets that lateral anchor go, then the two recti just come straight and come together.
So Diane, what I'm trying to visualize is like an analogy of a bridge
Yeah.
And the support bridges. So when TA is activating, the support bridges on either side of the bridge are pulling apart. So the bridge is taut.
Yep.
And when TA lets go, the supports on either side of the bridge, they collapse together and then the bridge sags. Correct?
Yes. Now, whether it sags or whether it pops out depends on what the diaphragm's doing. So if the diaphragm is descending and increasing intra-abdominal pressure, it will pop that little bit of lax tissue out of the belly, and you'll see doming, and you'll see some of those later. But when you have a negative intra-abdominal pressure, maybe this is happening on her exhale breath or whatever. Maybe she's holding her diaphragm up in her thorax. I don't know. And some women can do both. They can flip this little bit of lax linea alba into their tummy and out of their tummy at will, right? Wow. So it's all about pressure. It's all about intra-abdominal pressure, right? But it just means it's lax. There isn't enough tension there.
Okay.
So in 2020, Sandra Glupe, again, as part of her PhD with Kari in Norway, wanted to look at the effect of a postpartum training program on the prevalence of DRA. Like, does it fix it? Does it make it go away in postpartum women who'd had one baby? And they did an RCT on this with 175 women randomized to either an exercise group or a control group that had no exercise. So they defined DRA using finger width measures, and it was defined and it's commonly used in practice, greater than greater than 2 finger widths at 4.5 centimeters above the umbilicus, at the umbilicus, or 4.5 centimeters below. And if you look on the bottom here on this slide, this is a different study of Corvino et al. And this was a smart thing they did, because many researchers, several, not many, would only measure at one point. Now, these are all the different variations, the different types of stretches. 5 anatomical patterns is what Corvino has described here. And this is a really significant study because it certainly resonates with clinical practice. You see some women who are only separated or stretched above the umbilicus, like this type 1, 59% of them are like that, I would agree. And then type 4, they're stretched from, xiphoid all the way down. And then there are some that are more stretched, not many, just below, but I have seen this, right? Yeah. So we have to measure at all 3 regions, like below the umbilicus, at and above, because you don't know what type that person has. So they took that into consideration with this study. And the program started really early. It started in the phase where natural healing is going to be a variable, where just the reduction of pressure and taking away the pressure over time is gone, right? So it started 6 weeks postpartum, and they did a 4-month program where they had people come in weekly to a supervised class that really focused on strengthening the pelvic floor, because that's what the Nordic group is really all about, in addition to daily pelvic floor muscle training at home. But their program also included strengthening exercises for the abdominals, the back, the arm, the thighs, stretching, relaxation. So it was what we would do in practice, right? It was a whole program. And they then did a follow-up at 6 months and 1 year. And they also gave these gals a self-report questionnaire on how often they performed their exercises. So they were looking at compliance and whether dosage made a difference at all. Here's the conclusions. This program, which is what we would do in practice, and it's a good program, in addition to daily home training, did not reduce the prevalence of diastasis. What do they mean by that? No, it did not reduce the interrecti distance. And if diastasis is defined as one measure, we really have to ask the question, is the interrecti distance a valid measure of outcome? Okay, the IRD didn't change. And this was the measurement that was considered to be valid for determining progress, recovery, or outcome. And so it didn't change.
I want to ask, was there any soft tissue manual therapy done to these people, or was it all exercise based?
All exercise based.
Okay.
All exercise based. No manual, no taping, nothing passive. Only active exercises.
And then, so Diane, we've also talked in the past in some of your other interviews years past about the difference in people who only have, maybe a 2 to 3 finger separation versus those having 4 to 8 finger separations. Like there's quite a distance. What I see in my practice is that women who have only a 2 to 3 finger, more mild condition of separation, they tend to heal on their own.
Absolutely.
But the larger ones those are the ones that need more support. And so did this study include both of those camps, or?
Yes. And I need my notes on that to sort of tell you. They had some mild, they had some moderate, and they classify them according to Corvino as well. And they had a couple of the severe ones. And it's a great question, Lynn, because the thing I want to challenge today is whether or not the interrecti distance should even be used as a measurement tool for outcome. Like, does it mean diddly squat?
Right.
Should we even be considering it?
Well,
so in 2016,
we
introduced this distortion index. So Paul had was able to put a number on what we normally do as depth. How far can I sink my fingers in? So far we've been talking about width. How wide is it?
Yeah.
Without considering how deep is it? Okay.
Yes.
So whether they do a curl up or whether it's at rest, how far can you sink your fingers in? Yeah. And so what we did long time ago now is that we looked at the difference in the strategies they used to curl up. We measured the interrecti distance at rest. We then had them to just do an automatic curl up with no conscious pre-contraction of the deep system. Now, some of them might have been, some of them might not. They didn't have to be able to isolate transversus from their internal oblique. And then what we found, and it's been found many, many times, is that women who've had babies have wider interrecti distance. Yep, your belly stretches. Yeah. But they don't have a distortion. You can't push it in. So what you measure either via ultrasound or feel with your finger in an abdominal wall, looks like this one below, which is fairly firm. It's not 100% flat. Nobody is, but you can't sink your finger in and palpate the viscera, right? That's not how you get to visceral listening. And so when you ask them to do a curl up, so there's a video running for those of you who are just listening. When the person does a curl up, you don't feel any doming or sagging in the midline. It's lovely and tense all the way down. And if you have the good fortune to work with ultrasound and you measure this interrecti distance when they do a curl, you see that the linea alba stays tense, straight between the left and right recti. And that interrecti distance doesn't change significantly. All right. There's no significant increase or decrease, which suggests that it's already under tension, even at rest, whether you pre-contract the deep system or not. And this is really different when you look at people with DRA. And what happens for them is that when they do a curl up, similar to several other studies, that interrecti distance narrows, comes together. But what we looked at that no one else had done was looking at, well, how distorted is it? Because it's difficult without an index, a way to measure this. And I can't do this clinically other than stick my finger in and see how far it goes. They all got more distorted. Okay, they're more laxity in the connective tissue. And yet when they brought on the deep system, what happened when they went from like an automatic strategy to one consciously using their transversus? Yes, the interrecti distance got wide, but the distortion got less. The distortion got less, right? And that's what you saw in the video I showed you before. And here's another one now. So this gal is doing a curl up and you see a small bit of tissue doming out. You can push that tissue in. You can pull the recti apart, which you shouldn't be able to do when all abdominals are working well. On ultrasound, you can see that she's not using transversus very well, that she's IO dominant, internal oblique dominant. And with that strategy, here you see the left and right rectus come together and the interrecti, the linea alba, be very lax. Give her a cue to connect to the deep system. And people who aren't working with ultrasound think, oh, look, the gap is closed because they can't push their fingers in anymore. Many studies have made this assumption, and it's not true. It hasn't closed at all. It has widened. It's opened, okay? And here you can see she's got a bit of an endurance deficit on her transversus, not working hard to stay on. And when she does that and curls, there's lovely tension, but the interrecti distance is wider, right? Interrecti distance is wider. So that was the summary of our paper. Yeah.
Yeah. Go ahead, because this is probably what I was going to ask you.
That's the summary of our paper. So here's some drawings that Paul Hodges did just to illustrate that. So here we are with this. The diagram on the far left is at rest, and you can see the stretched rectus abdominis, which is where we're at postpartum. And then when you do a curl up with no anchoring of the lateral part of the muscles, the muscle will shorten. And so when it shortens, it takes the pathway, the shortest distance from the rib cage to the pelvis. So this line straightens. So over here, it's a curve. And then when the rectus is contracts, you can see it's straight. And so that's why the mechanism as to why the interrecti distance comes together. But as you can see on the drawing and below, it's your bridge analogy is perfect, Lynn. It's you got a wobbly bridge, right? You got a wobbly bridge. And then when transversus contracts and pulls and takes the tension out of the rectus, takes the slack out of the rectus sheaths, and takes the slack up in the linea alba, sure, the interrecti distance gets wider. But then when they do a curl up and broaden the rectus abdominis, now we have this lovely stiff anchored base for the oblique abdominals to work on top of. So it is, Nicole Hills has shown that it is trunk rotation. Sandra Blupe didn't measure rotation in her study looking at function. They measured trunk flexion strength, and they measured ability to sit up with women with DRA, and both of those were weaker. They didn't look at torque, at rotation, but Nicole Hills has. And it's the one task that I see clinically that even the women that we trained, which is the second part of this lecture, and we trained them hard and we trained them for a long time, they did phenomenally well, except for trunk rotation. Okay. It's the one parameter that they weren't able to get back.
Yeah. Well, that makes sense if they don't have that translation across that linea alba.
Doesn't it?
Right.
So, in 2016, we concluded that if we only focus on having women do things just for the sole purpose of narrowing the interrecti distance, that you may end up with more distortion. And that's going to have implications for abdominal contents control, which is going to be possibly cosmetic, but it also will be functional for the thoracolumbar junction and for the lumbopelvis, depending on whether you've got a Corvino type 1 or type 4, is it above, below, or the whole thing? And that we may get better results if we focus on strategies that reduce distortion. So here's my gold nugget for today, for this part of the session. That alone, the interrecti distance is not a valid measure for guiding training, nor for measuring outcomes of any intervention in those with DRA. Done. We're done. We're done measuring the interrecti distance. We've got an RCT now that shows us that it doesn't change with good training. And if we monitor distortion, my question is, will we get more accurate information that helps guide clinical practice? And I think we can quantify it quite simply by at rest. You push your finger in, and if you know how long your finger is, you can push your finger in. And sure, we can do intertest or reliability studies for this, or develop some gauge or monitor or measuring tool that measures how far do we go until we start to get a certain amount of tension. But that's what I use. It goes in one IP joint, and my one IP joint is 1.5 centimeters, and my second one is 2 point something or other. So I know exactly how deep it goes by the depth of my finger. Now, we won't have inter-tester reliability because our fingers are all a different length, but if we use digits, but if we go with centimeters, we can.
Yeah.
So
Diane, we can we determine distortion on ultrasound?
no, not with the 2D ultrasounds that we have. You have to have the $250,000 machine that does elasto ultrasonography. So what Paul does when he measures these is he blows the ultrasound image up huge. He traces the distance between the middle of one rectus to the other, shortest path. And then he traces the shape of the linea alba in a JPEG image during their curl-up task, whether it domed or sagged. He traces that pixel by pixel. And then there's a software program called ImageJ that calculates the area, the bounded area of that shape. That is then divided by the distance of the bottom, the shortest distance, and it gives him a number, which he's called the distortion index. And the Linda McLean's group in Ottawa, was Nicole Beamish, I believe, in 2019, actually has validated that index as being a measure of distortion. And Paul did it using 8 subjects using his elasto ultrasonography machine. So before we used it to and published it in the trial, he validated it. But of course, we didn't do the studies to validate the index like you normally would do in a PhD. So from a research perspective, we are really trying to encourage researchers to use this distortion index. And part 2 will tell you why. If the interrecti distance doesn't appear to change over time, once it's plateaued, because we see that consistently in some they get better, right?
Yeah.
But in the women who get better meaning when the gap naturally gets less than what it was 6 weeks postpartum. I can tell you right now, I don't think we have much to do with that. I don't think we have much to do with it. I think it's natural healing that happens over time. Once it plateaus, it doesn't seem to change. But does distortion change?
Dun, 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 dun.
Da, 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 da. Does distortion change?
Yeah.
So here's my conclusion. The interrecti distance is not helpful for guiding us in clinical practice. You know, if you're looking at it in a crunch and it narrows, what does that mean? It may be that transversus isn't strong enough. It may be it doesn't have enough endurance for the task. It may be that it's not working. It doesn't mean you can't get strong. It doesn't mean that you need it for sagittal plane movements, for staying in a sagittal plane and picking up the laundry basket, picking up your child, doing a deadlift. It doesn't hold you back from doing anything in the sagittal plane. Okay. So it doesn't matter how wide it is and whether it domes or whether it sags. It has not been shown to be a useful measure of much of anything other than cosmetics and fear creation.
Wow. Okay. That I hope everybody understands the importance of this, because I think, you know, our go-to, our sense of getting better is that distance getting smaller. And you're here to tell us that that's not what we should be looking at, everybody.
Not what you should be looking at.
Yeah, awesome. So Diane, tell us a little bit, what are we going to be talking about in your summit interview? Where are we going next?
So in the midst of this massive confusion around the interrecti distance and the discovery of distortion, we had this idea that could we treat this condition like a tendinopathy? Could we treat this and you know that for Achilles tendinopathy and gluteal tendinopathy, what do we do to fix these? We load them, and we load them a lot, right? And it takes a lot of time. And so has the research gone on for long enough to see any change? Is 4 months of training enough? When here we have Alison Grimaldi and Jill Cook in Australia saying Achilles tendinopathy, gluteal tendinopathy, go 18 months. You've got to go 18 months, 2 years, the time it takes to restructure a tendon. Well, is this true for some of these people with DRA? Are we pushing them to surgery too fast? Do they need more time? So we wanted to develop a prospective longitudinal trial and train women hard take the belly to a fatigue point, train it like a tendinopathy. And we did this through the pandemic. We did this for 3 years. And that's when I'm going to tell you what the outcome was.
All right, everybody, stay tuned. Please tune in to the Birth Healing Summit in April, and we will be talking more then, and you can find out this juicy the juicy tidbit Diane will be sharing then. So thank you, Diane, for helping us to become aware that the intra-recti distance is not what we should be focusing on, but more of the distortion and how deep do we go in there and what's really happening, and are we changing distortion with our treatments?
Yeah.
So.
And I just want to say a big thank you to the Nordic group and to Sandra Glupe for her RCT, because, there's been a lot of disagreement between the two groups in terms of what's relevant and what's not. And without studies like that honestly say, well, she said the prevalence of DRA doesn't change. And what she was really saying is the interrectal distance doesn't change. And studies like that really make us sit down and think about our thinking and think about our myths and think about what we're doing. And step by step, we're getting there, I think.
Awesome. Awesome. Well, we really appreciate your work and helping us to figure this out. So thank you for all that you're doing as well, Diane.
You're welcome. It's fun.
Yeah, it is. Okay. Well, thank you everybody for listening into this episode, and please check out Diane's new ebook. We're going to have the link in the show notes for you to access that. It's an amazing resource for us as practitioners. So please make sure you check it out in this new ebook format. So thank you for doing that, Diane. That's awesome.
Yeah, thanks for the shout out, Lynn. Appreciate it.
Yeah. All right, everybody. Thanks so much for listening in or watching in. If you're listening to this in audio, please make sure you check out the YouTube video so that you can see the wonderful PowerPoint presentation Diane presented to us as well. All right. Thanks, everybody. Take care. Bye. Today's podcast was brought to you by the Institute for Birth Healing. To discover more, visit instituteforbirthhealing.com. To claim $50 off any online course, use coupon code podcast50 at checkout. Till next time, I'm Lynn Schulte, founder of the Institute for Birth Healing.